and welcome to this online event, It Takes More Than an EMR. I'm Vaught's Marketing Manager here at Formfast, and I'll be your host. There's a lot of buzz around electronic medical records, or EMRs, in healthcare circles. A number of other key technologies remain invaluable to transforming hospital processes. Leslie Owens from Forrester Research will be joining us to share her insights regarding a collection of technologies that will help support meaningful use. Before we started, there are just a few items to go over. I'd love to hear your thoughts and questions during these events. Please submit them in either the Q&A or chat panel on the right side of your screen at any time during the presentations. Select them and present them to the speaker at the end of the session. Second, know that the audio for our meeting will be broadcasted through your computer speakers. If you experience audio difficulties, please send a message to the host so we can approve you to join the teleconference. When connected to the teleconference, make sure your computer speakers are muted, otherwise you might hear an echo. I'd like to turn the presentation over to Leslie Owens, a senior analyst at Forrester Research, which is an independent research firm.
Thank you for Formfast, and thank you for this opportunity to have.
She'll be sharing a presentation entitled "Electronic Medical Records Need More to Support Meaningful Use." Leslie, I'm going to turn it over to you at this time.
Formfast, and thank you for this opportunity to have a chance to talk about electronic medical records and how they need to do more to support meaningful use. There's an opportunity to use ECM and BPM and other technologies to hospital processes. Here's our list. We're going to be talking about healthcare providers and the challenges they face. Move on to talk about Forrester's maturity model, which acknowledges that different providers come in all different sizes and may have different funding limitations as they think about where they look to get to for an optimized digital healthcare delivery. And talk about the challenges for healthcare payers as well. Talk about ICD-10 and transformations and coding and transactions to be processed and the protocols to support that. To provide a blended approach to talk about both provider and payment side of the healthcare reform. We hear about EMR platforms and packaged and structured apps, but we see at Forrester a role for strong enabling technologies that have done in other vertical sectors, ECM, BPM, eForms, and how they could play a role in the transition to new healthcare information processes. Begin to look at the size and scale of what we're talking about, and it's quite large. The Family Foundation estimates $150 billion spent on U.S. healthcare and insurance administration. And inside that is not just the delivery of healthcare, but also all the administrative activities around that. And this and the chance to reduce the administrative cost is what's behind the HITECH Act and an economic stimulus package, which said we'd like to see more electronic information and specified technologies and formats. We also talked about requiring meaningful use of those technologies, trying to foster behaviors that will encourage transformation. Behind this are sizable, $20 billion towards healthcare, hospitals and physicians between 2011 and 2015. We also to achieve that meaningful use. Of steps along the way, including trying to foster more engaged patients, electronic prescriptions, and claims in digital formats. Through all this, we can see a way that a portfolio of agile tools will enhance the core critical systems transforming and moving their systems towards. So to these two worlds of the EMR packaged applications and all the untamed processes that have a range of content management and loose collaborative tools to support are not integrated. And that's how we see in the administrative costs that things are so high. Making a significant investment in the packaged applications, and that's part of the vision for running a hospital and having future digital integration. The emphasis around those applications, though, is towards structured data, putting fields in databases, and pulling processes that have a single well stored. The same vast amount of untamed business processes that are impossible to model in advance. They're ad hoc and chaotic, These are ways that people work with information, create and consume information, and enrich information. Systems and processes, documentation and correspondence between patients and providers, etc. These siloed processes can be helped with search and collaboration and business management and business rules. They try to create a way to coordinate across these processes using technology to try and tame the processes. About this lack of structure and non-valued activity that is hard to control and wrap your hands around, we can see that there's a set of technologies that could sit above the core systems that we see on the left, the compliance and PACS and EMR and clinical systems. Systems are expensive to make changes in and to adapt to. The hallmark of that type of application is that the people adapt to the application. What you can do is try and understand how people work today and embed that best practice into the application, but the application is more rigid and hard to control and change. With the way that these other tools that work with information are formatted to be able to utilize content management with flexible different ways to have templates and workflows and control information. Collaboration tools that allow you to coordinate and share, talk about discussions and loose conversations, bring them together from a range of different people. We've got BPM technologies that help you do process design and redesign. Analytics, which is one of the strong areas where we see technology supporting the future of healthcare. People are going to need to provide transparency into macro activities that are happening and be able to identify patterns and trends in the information. Talk about Forrester's healthcare model. It's a survey-based healthcare model that we introduced last May, and it begins with phase 1, which is the current state for 50% of the providers that responded to our survey. Phase 1 looks like a lot of paper. You've got the dominance of physical charts, paper, microfilm, and some amount of digital capture. And right now, the people in this state don't have a cost structure to invest in EMR. Brought in something like this, they may be years away from it. And what providers want to do is they're incented by these potential bonus payments, and they're wondering how the technology can help them get to the amount of physical charts and moving towards digital information. So they're thinking about retrieval, access, discovery, faster recovery. When we think maturity model, we're tracking a couple of different components. The around access is it to pull together information that's stored in different formats in different places, file cabinets and shelves all over. In particular, are tracked down there in different repositories and represent a big administrative cost function. On the side, we still see a dependence on static forms and handwritten information. Here, in particular, when it comes to records management, people are making only the paper version of records than what we see in organizations and other industries where people are managing records in place, digital records inside the systems where they're created and stored. It is important going forward, moving beyond the phase 1 of this maturity, because we need to have evidence that people are taking care of personal medical record requirements and monitoring the retention and disposition of content. Disposition could mean deletion, but it can also mean placing them on hold and carrying them through until the time when they should and can be deleted. So let's talk about to move beyond phase 1. We put the 2 main categories to get away from this physical repository dependence. This is to ease into capture and imaging and forms automation. This is where you could, for example, print barcodes on all the on-demand forms from your different systems and start to create a linkage from EMR to content management. You start to prepare an ROI analysis for backfile scanning and try to print on demand and eForms solutions. It may have, for patients, you start to scan them in, and for existing or legacy patients, you depend on physical paper. What is trying to wean caregivers away from paper. having a more form-centric model, followed by data-centric navigation in later phases. They separate clinical data from administrative data to clinicians. At this point, think about moving into phase 2. After you've done those changes, you can start to think about access to standalone repositories, as well as the presence of, in this image here, a new medical records portal, a place to coordinate the different tools and techniques that are part of your ecosystem. So we see here you have forms automation and workflow for some basic processes, a link that will go back to your EM unstructured information, which is still a pretty big bubble. And then you have all the things that comprise the medical record and coordinated through that portal. Strategy here, you want to towards this cross-system medical records initiative and have a cycle for ECM in place. From phase 2 to phase 3, we have a couple of steps of guidance. The first is around workflow, a list of different provider workflows and starting to prioritize which workflows can be automated, eliminate static forms whenever possible, and review emerging solutions from ECM and niche hospital workflows and eForms solutions. Around the DICOM images, creating a link from that image and diagnostic summary to the patient record through the portal or EMR, and engage IT and HMS departments to develop policy for DICOM retention. Phase is the final step, which for a lot of our survey respondents is 5 to 10 years away. This is an interoperable patient record. See here a place where a clinical data repository that can drive analytics. The EM is a central bubble, and your administrative content is integrated with your through this role-based collaborative gateway, where diagnostic codes are going straight through claims instead of adding to that waste that we saw in the original slide here. What's new about the interoperable patient record is that you have health information exchanges. This is our visual of where the patients take control over their information. You've providers like HealthVault or Google or Microsoft Connect. They're just on interoperability. And this is a responsibility on the shoulder of payers and providers to make the kind of information compatible with these future HIEs. Talk about the top administrative workflows that can benefit from workflow and forms automation. A range of different kinds of those untamed processes we talked about before that were supported by agile technologies. Contact processes, abandoned processes, and so-called specialized processes. Some of these here that we want to make sure things like late charges or termination paperwork are auditable and collected in digital form. These things are manual, and not only is that inefficient in the work stream of today, but it also creates this downstream inefficiency later, which is towards the phase 3 of optimized digital information. The second aspect to look at with workflow is around clinical information. You have your wellness management, your employee surveys, all kinds of ways of tracking long-term chronic illness, and you make existing case solutions that are fit to purpose. And these are probably going to be replaced by more horizontal, agile content systems from providers like IBM, EMC, Fortis, or Pegasus systems. Another thing that's likely to happen as we think about clinical workflows and how that might change is that the jobs themselves are to be different. The oriented responsibility of people whose role is to be a business process coordinator are going to need that kind of context-based and progressive case support. Help people build a case management strategy and get towards more tactical workflow solutions to coordinate across these different departments. Think about the healthcare provider scenario, and now we'd like to move on to think about challenges for the payment community. Certainly, providers providers have to present information in a certain way in order to get paid, but payers have their information throughout their system. A different set of responsibilities thinking about the new healthcare delivery models. We in some ways to the process transformation opportunity that was available when the financial industry became more regulated. The Healthcare 2010 is we're thinking about lower cost structures, agility and transparency, and through transaction processing. There are not a lot of challenges facing this community, but it's also unclear what's going to be pushed to the forefront. We know healthcare reform and high tech, and the change is inevitable, but what is going to happen and when? The root cause here may be around the coding structures, the required reporting, and rules management that's required for the long term. I like to think that disruption is an opportunity for a business process perspective, a chance to rethink the way that rules are managed today and processes are handled today, and remodel them and think that in an efficient manner. We'll show you can move to these unbundled core systems and administrative simplification made possible when there's standards between payers and providers. Transparency is critical too. We've spoken a little bit about 5010 and ICD-10 and what that conversion initiatives are how they're going to drive process change. Voluntary guideline for 5010 conversion, and going forward, we have that 50% of the payers think that they'll be able to make that voluntary goal. ICD-10 is about classification of diseases, and when we think about all of the paper around billing and coding, when the application moves from ICD-9 to ICD-10, we're going to be expanding the classification to thousands of additional diseases. So that is a great opportunity to prepare for process change. Reasons to do it. What will you get? Improvement to adjudication of claims, making reimbursement more uniform, decreasing denial rates, adding performance measures, and allowing more advanced analytics for the healthcare system. This is potentially the most important possibility. The ones that we mentioned before are affected, but almost all payer processes are affected. We're looking at the health payer environment, sort of a generalized view of all of the different things at work. As we go around in a circle, we've got claim acceptance, analysis, and payment. This is where 80% of the work is going through clearinghouses and provider networks. All paperwork needs to go be an ICD-10 by 2013 in order to be processed. You've also finance systems, revenue management systems, provider network management. This is where case management can really help. When we look at things like enrollment, customer communication, and workflow across systems, they indicated that 4 to 6 is the average number of correspondence systems across the payers that we talk to. We need a multi-channel strategy for this. A way to audit what's sent to whom when, and a way to de-emphasize print. Another this is simply to say if you don't perform, you don't get paid. So it's an accelerating trend dragging the healthcare industry to be more in line with other performance and metrics-driven industries. Industries that we follow, like manufacturing, they have Six Sigma in place, all kinds of supply chain processes, and healthcare has traditionally been behind, including a more metrics-driven approach. Things like pay-for-performance programs, which are evolving to include quality and cost metrics, and new incentives that are going to encourage providers to increase the quality and safety and demonstrated improvement of patient outcomes. We expect to see increased transparency through public posting of quality and patient safety data. So this is the reality where current systems, where payers are not ready for these changes. We said that this is a provided catalyst for change. ICD-10 will force payers who are dealing with too many core systems, as many as 4 versions of core systems, time to consider what to do, whether you're upgrading or replacing. You're going to see a lot of upheaval here. So whether or not you're ready is whether or not you have the IT resources that you need. as well as how ready your partners and vendors might be. Where health payers stand, 64% of them said that they're developing implementation stand here. Nearly 48% of those with a single core system indicate that they plan to upgrade, while 30% plan to remediate, 20% plan to replace an existing system. Speaks of uncertainty and upheaval in the market. We know progress is hard. Of those with multiple systems, 42% plan to upgrade, 14% plan replacements, and 40% plan to remediate existing systems. It depends on your existing infrastructure, what you're going to do. The strategy depends on the current state of your systems as well. Do you have a single core system or multiple? Do you carry apps or provider-generated apps? How comfortable are you with different levels of outsourcing? What's your market approach? Do you have a consumer health plan or value-based benefit products? And where do you stand with government reimbursements like Medicaid? Acknowledge at the beginning the different levels of payers in terms of number of members, the amount of regulation. So we've got your payers that are facing the most drastic upheaval in their current state of how they do business. More than 1 million members, they have hundreds of staff working through these issues, and they're facing dramatic plans that are on tight timelines. For two payers that have less than 1 million members, they're probably more concerned with state and federal regulators and regulations. And they have the conversion, the resources to enact conversion today. So their challenge is how to select which problem to attack when. The payers, the smaller, less than 500 member organizations, have IT and capital to address these problems. They're going after SaaS-based and collaborative solutions. For dynamic case management, in particular on care management and reimbursement, places where there's a lot of exception processes. And this is, we reflect back on that combination of agile technologies, things that you work with and to the way people need to model out their processes. This is not as production-oriented process management as we might see in one of those core claims applications. In the end, what people need is dynamic tools to manage cases as they evolve. We talk about dynamic case management, a combination of things with a targeted platform. Here, a blend of analytics, experience, EM suites, and ECM suites. On the analytics side, you've got mechanisms to adapt to the business needs for analysis and reporting. Your experience is the information workplace. It's a contextual way to access the information that you need. It may be collaborative information, formal content information, social information. The B suites adapt and automate business processes. And these suites work with business and transactional and persuasive content, as well as have document management, records management, and customer communications management capabilities, trying to structure and automate the way we work with information. Forrester some great research around dynamic case management, and we can really see how that could fit into the future of digital health care. Where you might need to manage chronic cases that go for years and years, you can imagine the need to coordinate around a given case. No people involved, the content involved, a way to collaborate and communicate with other case managers to respond and track the history here. Follow the right policies, follow the established processes, link in the correct data. All a great scenario for dynamic case management, which is necessary to make sure you're getting reimbursed at the right level. There is an opportunity, I think, for business process-oriented architects to take a business process-oriented view, what we're calling here 21st century business transformation, but really is 21st century healthcare. Our own client interactions, that people whose job is to work as business process professionals are getting a stronger role in organizations. We say we're starting to report into the CFO level, CIO level, or maybe a clinical area or claims area. but that they have more power within the claims process, and they're working on building these business architectures that are going to transform the business. They're to blend these tactical reform tasks that they face with a long-term view of the way that new rapid changes and how that's going to affect our way of doing business. We can see a process maturity curve that begins with IT, where you have your application development pros and your enterprise architects starting to work more closely on the business side, where you have them evolving into a role of VP of Business Process Improvement or Manager of IT Business Systems, and then coordinating and governing alongside people in human resources, people in finance, people in operations, etc. So we end a call to action around the opportunity afforded to the people who serve in this role. As you can see, as you are going to be moving through from maturity from paper charts to this cross-provider electronic health record of the 21st century, you'll need a way to support both the structured and unstructured work and the different applications in your portfolio that will support that. Thank you for your time. I appreciate it.
Thanks for sharing your findings, Leslie. There's a lot of great information there. I'd like to remind our audience that we will be collecting questions for the Q&A portion of our webinar at the end of the session today. Once again, feel free to send questions to us at any time via Q&A or chat panel on the side of your screen. Next, Director of Product Management, Sean Curtis, will be joining us to give us a brief explanation of how Formfast automation solutions transform hospital processes. Sean?
Thanks. If you can make a presenter, I'll share my slides here.
There you go.
Right. There they are. Again, and thank you, Leslie. That was a great presentation. And again, as Aaron said, please submit some questions, and we'll be taking those questions after my brief overview. What I'm going to do is just give a quick look at what Formfast is. I know a lot of you might already be familiar with Formfast. What we do, where we're at in the marketplace as far as your process improvement, your of not forms, but the processes that are involved with those forms and around those forms. Formfast, like I said, we've been in this business for nearly 20 years now to work with hospitals. We strictly in the healthcare market. We're fully focused on healthcare and the needs of our customers in that way. So we're not dealing with industry and other areas. We focus our software development on the needs of hospitals and IDNs. So we're really committed to going back to our customers and working with our customers and understanding their needs and helping them deal with the issues that they see and how they can take the software that we have and work with it in new ways, and show you some of the ways that our software helps across the spectrum of the maturity model, similar to the maturity model that Leslie had outlined. So when we talk about improving processes, it can be anything from getting rid of blue cards that are stamping patient information onto forms to putting codes on those forms so they're ready to be scanned into an electronic system and automatically put patient information onto those forms when a person is admitted and those forms are generated, or to directly go through the process without ever being printed and kind of eliminating the idea of a paper form, yet still using the idea of collecting that data to then increase your knowledge of what's happening, your process knowledge, and also increase your knowledge and the ability to do analytics on the data you've collected. So those are some of the process improvements that we're hoping to help you achieve. So going back to what Leslie was talking about was the maturity model they've kind of identified, where there are, she pointed out 3 phases, and related to Formfast, this is kind of how we see it as well. There are 3 phases. Phase 1, down in the very bottom of this pyramid, all the way up to phase 3, where we're talking about integrated systems and process management and analytics and things like that. And what we do is we provide technology that helps across this entire maturity model from bottom to top. And what we want to do is, wherever you're at in this maturity model, be able to work with you at that level and give you action steps and give you the ability to move up that level, up to that more advanced process management level. And so that's the nice thing, is that you don't have to be at the bottom of this to start working with Formfast, or you don't have to be at the top of this to start working with Formfast. We're at in this spectrum with the technology that will help you with that. Breaking it open here and looking at this first phase, we're still dealing with a lot of paper. We're dealing with a lack of integration between getting that paper into a computer system, or getting that paper automated so that patient information is coming onto it, things like that. So really, being in the business for over 19, 20 years now, that's really where we started at, was being able to eliminate the process associated with scanning or labeling forms and costs of pre-printed forms, the storage, the distribution, the waste of obsolescence when those forms go obsolete, being able to make those happen on demand, and dynamically printing barcode and patient information and things like that. So that's the phase 1, and I'm going to point back to what Leslie said earlier. She kind of timelines, and what we're seeing too correlates with that hospitals are kind of mixed into this mature model, and phase 3 may be 5 to 10 years out for a lot of them. And we're kind of seeing that a lot of our business is happening in phase 1, and a lot of our business is also picking up in the other phases as well. Phase 2 is a little bit more, and then phase 3 is catching on. So we're kind of seeing that correlation as well. So we're not saying that you have to be at the top of this. You can start anywhere. In the phase 2 portion of it, we really look at the fact that we've now gotten your forms and things automated, and now we take that to the next level, where we can not print certain forms, maybe send those directly to your EMR system as needed, or generate on demand at the nursing station, or collect electronic signatures for consent and papers and all those areas where you're collecting the signatures, kind of smoothing out that process and helping you less paper. So maybe if you automated the paper, but you still have paper. Phase 2, maybe we're going to get rid of some of that paper and go directly, collect a signature electronically, never print that paper out, put it directly into your archiving system, recording your EMR and things like that, so that we're doing more integration, bringing your business rules to the generation of these documents. So we can do a lot of that stuff as well. And what a lot of times talking about today too is the 3. This is where the market is. This is where everybody wants to go, and this is really where we get the most value out of our technology, about all the technologies that we've accumulated over the years as hospitals. This is where we can now start to bind those together and use that through collection and through kind of getting rid of those silos and kind of breaking down those walls and sharing that information across these different silos. And so Formfast has workflow products that will help to pull information into other processes, maybe relate claims information with information, relating product information, or your charge information more with your claims information, making those connections will have gaps between your systems, and automating those untapped processes that Leslie mentioned as well. So a lot of processes just occur in your organization. A lot of things just go on forever because nobody said there was a better way to do it, and it hasn't been addressed. But we provide a technology to help you kind of you can do improvements, where you can cut some time, where you can collect better, where you can understand your processes better by using more tools or different tools. So talking about those and the areas that we can affect. So with our workflow tool, we have applications across a broad spectrum of areas in your hospital. So we can work within administrative applications. We can work within compliance. We can work within revenue cycle. We have things, with predetermined applications for things like managing your RAC audits, managing communications between physicians and billing and coding staff, managing your charge master and the process around changing those things, just the communications and the processes. So all that can be automated, and these are the areas that we affect based on the line of business. So these walls start to come down as you move to phase 3, where it's more about the actual run as a business than the point solutions that many of us have now in our portfolios. So we see it with our workflow automation technology. There are kind of these untamed processes, and there are two types really. There's automation, and then there's process control. So different levels of thought along these lines. One level on the left is the process automation. So we're just looking at, okay, we do a purchase request now, for example, and let's get the paper and let's make this better and analyze really where that needs to go and who needs to approve it, how that information is collected, and then maybe track against that. So there's a form, and it kind of goes through a workflow of approval and request and collaboration, and then it's done. Some examples. That's an example of a kind of a straight-through, simple process that went from a paper process to being an automated process. There are those in hospitals today. Event reports are simple processes that can be automated. Things that are just simple. A request into someone and get approvals or track that data. The control side of it on the right hand side, now take out of these processes and kind of group them together into an application that we're going to track. So a process where we had process control on top of this might be an example, say a RAC audit where we have someone or a group of people in your organization who's responsible for making sure that all the pieces and parts of that audit are completed in a timely manner. So they need to track through, and there are several things. There are several data collections. There may be scanning images. There may be sending things through mail. There may be collaborating with people on the legal response to the RAC audit. That's where we tie all of these things together, where we have not only are we just having a form that goes from person to person to person and collects some attachments and some signatures and approvals, but looking at in a larger picture, maybe it's across departments, maybe it's across those business focuses that we looked at earlier, but somebody's responsible for that, and they're going to monitor those processes. They're going to collect the analytics on two sides of it. One side of it is that the team and the people involved in the process itself, just the movement of that workflow process, that's trackable. And the other side of it is now we're collecting this granular data. So the difference between granular data and maybe doing this through paper processes is that in a paper process, in the end, the best you'll have is probably a scanned image of that paper. If you in an automated workflow process, what you collect each document on that form document, and now you put it into a database, and now you can start to see trends. You can start to do some analytics on that. You can do some regular reporting so that you can keep those who are in that process or involved in those processes. You can keep them up to date on what's happening, and you can point improvements towards those things. So a couple of more detailed examples of these two types of workflows, starting with the simple sample. So what Formfast do? So it looks as a purchase request example. So a user is going to make a request of their supervisor. They've typically used a form to do that. So the first thing we can do is take a look at that form and look at the business rules on that form and turn that into an electronic workflow. So we're going to purchase request, turn it into electronic workflow, publish it online so that your users have access to that when in a repository, so they can click on that and start a workflow request. When they click on that, we know things about the users. We know who they are. We know where this purchase request has to go. We can base that on who started the request, to what department they're in, things like that. So for this form, it's very clear that there's a business rule right here that says the VP approves if it's over $10,000. So as this form is going through this workflow process, at that point, we're going to look at that form, we're going to look at that field value in the total, and we'll change the route and to the VP because it's at this one is $18,000. We also know who the initiator of this workflow was, so we can route to their specific supervisor rather than hard coding that. So we can be very flexible, and we can be dynamic and driven by the content of the request, which is another feature that we have to enable you to make the workflows not only in one area but across the whole organization. So once we do this, we get to I skipped to the slide here. So this is kind of the high-level look at the entire workflow. So this got the business rule, and then once it's finished, then it goes into a database and an archiving system. Rules base that would tell it to go up to the VP for approval, and